And I always caution our learners, especially, but I think this is true for everyone, no matter where you are in your career, to sort of take a step back and ask yourself, am I making this decision based on good evidence, or am I making this decision based on fear? Because hopefully we don't treat, cardiovascular disease out of fear, usually. Why would we treat pain or not treat pain because of our own fear? Hello, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am Grace Pratt, production editor for the podcast, and I am joined by some of my co-hosts. We're going to have an awesome discussion today, following from something that we started to talk about at the end of last month, talking a little bit about the culture of medicine that we work in and the larger system of the healthcare system, and how some of that interfaces with our individual perspectives and how that impacts the work we do, both in ourselves and with our patients. But first, we're going to start the way we always do with our icebreaker question as we go around the room. I guess it ties in. So we're going to be talking about fear, and we're going to talk about fear in medicine. And I'm going to date myself by saying this, but when I think about fear, sometimes I think about the ancient reality show Fear Factor. Did you guys ever watch Fear Factor? You're going to dig way back in your memory,
Oh
right?
yeah, yeah.
The original Joe Rogan.
Yes, right. And I couldn't watch a lot of it because I am easily disgusted. And
Yeah.
there was a lot of disgusting stuff. And so I am not going to ask you a question about, like, would you rather, Fear Factor, pranks,
Good.
gross. No, thank you. But I would never, you could not pay me enough money to go on Fear Factor. For one thing, I know that I would lose and then I would get no money. So anyway, not for me. But it did make me wonder, if you were going to be on a reality TV show, anyone that you can think of, what one would you like to be a part of? So going around the room here in our Zoom room, first we have Jen Thomas.
Oh, I'm first. I had a feeling I was going to be first, like blank. All right, I'll give it a shot on the fly. Jen Thomas, family medicine, addiction medicine at Morris Hospital, Morris, Illinois, and medical co-director, CFHA. Woo! I have to kind of own that co-director title with Laura. I'm still getting used to that being the, hi, I'm Jen kind of stuff. Reality show. Oh gosh, that's a tough one. I don't think I would, like you said, do well on any of the like Daredevil things. I guess I would say, if we get to like have like extra skills and like superpowers that we don't really have in real life but would be cool if we were good at, I like the American Ninja Warrior series. That's super cool. I would totally suck at that and like fall on my face, but we have a trampoline park, Sky Zone, near us that the kids go to, and like last Christmas break I was like, I can still do this stuff in my 40s, and like paid for it terribly the next day. It was like just hurting everywhere, like bashed the knee. My littlest guy Truman, he's 9, like he would be good at that. Like he can squirrely jump all over everything, so I think I try to like keep up and realize, oh yeah, aging
I
is a
love
thing.
that. It
Yeah,
is.
it'd be cool if I had the wherewithal and the physical skills to be good at that. I think it'd be super fun. So
I love
that's
it. So last week, one of my kids got it in his head that he really wanted to go roller skating, and they'd never been roller skating before. And so I took all of the children roller skating, and it did come back to me. We used to go at least twice a month. That was like the thing in my town, but it's not the same. It's not the same at this age when you were a kid. For one thing, the music was very different. There was no Don't Go Chasing Waterfalls. There was no Macarena. They didn't even do the hokey pokey or the
Oh, come on.
limbo.
You got hokey
I
pokey. If you're putting on
know.
skates, you better hokey pokey.
Right.
Or else
But I
they'll
feel
break.
you in the trampoline park, the roller skating,
Yeah.
all of those things.
Good.
Then we also have Neftali Serrano.
Hi, everybody. I am Neftali Serrano, whichever way you're able to say it. I'm the CEO here at the Collaborative Family Healthcare Association. And yeah, I'm not a big fan, to be honest, of reality TV shows. My sort of reality TV is sports, right? But I did grow up on Fear Factor, and I enjoyed that one quite a bit, just because there's this, gross fascination with being grossed out and seeing what people will do for money, that kind of a thing, right? But as far as current reality TV shows, I don't think I do very well at this, and either of these two that I'm going to tell you, but they would be interesting to me, and there are parts of it that I could do well with. So one is Survivor, and I would do horrible, like horrible at the game playing, like the like manipulating people and all that, because I can't stand disharmony, and just like causing chaos between people. So I would suck at that part, but I love the challenges. And, I feel like I'd be pretty, I'm decently athletic. I can do some of those kind of challenges. And I like teamwork. So like if we had a team, I could help the team do X, Y, and Z. So I think and it'd be fun to be on a tropical island for a little bit.
Yeah, I can see that about you. You'd be great at Survivor. Definitely.
So
I feel like,
that.
how when you do motivational interviewing trainings, you have to kind of basically like pledge to only use it for good.
Yeah.
Motivational interviewing would come in so handy on Survivor, like getting people to do things, getting them to think it was their own idea in the first place. Like that'd be a secret weapon in your back pocket.
It would.
That is hilarious. I'd never thought about that, Grace. You're right. You're right. Yeah. I suppose we could use our team skills too if we just reversed them and we knew exactly how to divide teams.
I'm telling you,
we know how to divide teams.
Something to this.
Yeah.
What was the other one that you were?
Oh, the other one was Dancing with the Stars.
Yes.
I'm not a good dancer. I'm not a good dancer at all. But it would just be, I think I would like the challenge of, trying not to embarrass myself.
Yeah, learn something new. And so a lot of Dancing with the Stars is about the charisma too, to keep going.
Showmanship.
Yeah, that's so fun.
Yeah.
Well, and I'm Grace Pratt. I am the behavioral medicine faculty at Integris Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma. And I would love to go on Amazing Race. I want to travel around the world. My partner and I really do like to travel together, and we also work well like as a team. So I think a lot of the things that you have to figure out puzzles and you have to solve things. Now, there is occasionally a gross challenge on Amazing Race too. And I think I'd have to be like, Chris, you got to take one for the team. You can't do it. But I think it'd be really fun. It'd be stressful, but it'd be fun.
You think you'd do okay with Chris? I mean, like that would be okay.
I think so. We obviously have taken much less intense trips than that before, but something comes up, and one of the things I really appreciate him is that when a challenge comes up, he rolls with it, and we both sort of respond to unexpected changes in the moment pretty flexibly. Like we can think on the fly, we can come up with a new solution, which is helpful when there are 5 children between us.
Parenting
it's
superpower.
Chaotic all of the time.
Yeah.
Honestly, the hardest part of going on Amazing Race would probably be arranging all of the child care that it would take for the months that we were going to be away.
Not as glitzy, but it'd be amazing to see all the schedules and
yeah. Yes. I would totally go on it with them. I think it'd be a lot of fun.
That's impressive. That's impressive. I'm not sure I could do that with my wife. I think we'd both implode at the same time.
Yep.
We'd be the couple that they would focus on for the episode because it's entertaining, because we're turning on each other, bringing up old wounds, and you always do this.
The cautionary tale, like, oh, what are they going to say next? Will they be together at the end of the season? Stay tuned. Yep, same.
Well, that is a fun question to think about, and thanks for chatting about it with me. I'm going to move us on into our episode. So, Naftali, do we have news and notes?
Yeah, we always have stuff going on here at the Collaborative Family Healthcare Association. So one of the news and notes is just simply like an FYI, we're doing so much now as an association. We've grown a lot. We have so many groups of individuals who are working on particular areas. So to tell you about it all would be too tough. But you can just check out all that's going on our events calendar. So if you go to our website, click on the menu at the top right, go to the events button, you're going to see all sorts of groups that are meeting. Those groups are reconvening now for the fall season. We've got groups, obviously our special interest groups like PCBH and our COCM group and our pediatrics and families and health group. But we also have lots of work groups that meet on value-based payment. We have a measurement-based care work group. We have an African Americans and integrated care work group. We have a work group that's forming around, or not forming, it's actually meeting around sort of redefining integrated. So there's all sorts of opportunities. Just look on the events calendar. You'll find it. Great stuff. This is just an open invitation. And then the other key thing to take note of course, is our next podcast is going to be a live podcast at our annual conference in late October. I think it's October 24th through the 27th. So if you want more information about our conference, still availability, obviously, for a registration at integratedcareconference.com. That's integratedcareconference.com. So yeah, so keep up with us. We've got so many great things. The only last thing is just a quick shout out to the work that Jen here and Laura have been doing as our co-national medical directors for integrated care. It's really just exciting to see the group of medical champions that they're bringing together. And that's one of the other groups that's going to be forming after the conference here. Just a special place for physicians, NPs, PAs, folks in the nursing professions, just the folks on the medical side of this whole equation that we want to be supporting for team-based integrated care. I think finally getting together and finding their voice. And this actually goes into a little bit of our topic today, I think, where we just feel like it's so important to give voice to the emerging needs of medical professionals as they revision what it means to work in team-based care. So Jen and Laura are really bringing this group together across the country to do peer support. There's like awesome stuff, like there's a Facebook group that's meeting for psychiatry and folks in consulting psychiatry in particular, and they're going to be moderating and facilitating some of that group. So there's lots of really, really cool stuff going on that gives me great hope for our teams and our professionals in different areas. So yeah. So again, CFHA.net is our website. Check us out, and we'll look forward to our podcast live at the conference in a few weeks.
I love that. I love the work that you're doing, Jen. And I love how like everything that you're talking about, Naftali, is community. It's community, it's connection, it's connecting people, it's connecting ideas, but it comes back to the people and their relationships. And that's one of my favorite things about this organization. I have one more tiny thing to add. After a kind of summer hiatus, we are continuing our coming of age series. We have 2 more episodes that are out and more that are on the way. If you are someone who watches our podcast or listens on YouTube, you're going to have to hop over into the regular podcast feed. So you can find it on SoundCloud. You can find it in Apple Podcasts or anywhere you listen to the podcast. You're finding the Integrated Care podcast. But we really want you to listen in on those stories. They've been so fun to do. If you've been missing Deepu's voice as much as I have, you'll also find an added bonus there because he and I record some commentary before and after these conversations through some of our really pivotal members through the history of our organization. So really invite you to hop over and listen to those. We've got some great feedback. It's been really fun. So, okay, let's talk about the elephant in the room. Let's talk about last month, we spent some time talking about some difficult things that have happened and the way teams that responded. And our conversation drifted over a little bit into talking about the things that we do because they're the right things to do, and the things that we do because sometimes of fear. And fear can be interwoven in our culture of medicine. And so I want to start by just kind of opening that up. How do we see fear bubble up? How do we experience it? How do we see it woven into healthcare?
I like the woven in. That's exactly the same like imagery I was thinking with this too, Grace, and contemplating where this conversation would go. It's definitely in the fabric of modern Western US medicine, isn't it? Because there's that, I mean, all of the things, the defensive charting and the litigious vibes and the don't delay in diagnosis or forget to do this, because there's that, whether it's spoken or unspoken cloud of you might get sued, you might screw up, someone could die, and then it's sort of a pushing down the fear, I think, at least in medical providers, to like, you have to kind of like push down or ignore fear. You wouldn't have the stones to show up to work and do anything if you're like, uh-oh, what if I'm on this tightrope and any moment I look down, it could all come crashing down and kill someone. I mean, that's a lot of pressure. So I think you kind of learn to live with fear, but I don't think we have I'll speak for myself, my culture, my system, a very good balance of like coexisting with fear in a way that's healthy, that keeps you, like the evolutionary, if you were supposed to be good, right? So you're scared of the saber-tooth tiger, so you run and it doesn't eat you. Like, that's the good part of fear or anxiety, right? But it definitely takes a turn into the maladaptive when it's the looking over your shoulder and practicing in a way that's just defensive charting, which I've heard that term many times in my training. So, and I'm sure I do the same. So yeah, that's kind of a pessimistic way to start us off. It's scary out here, but it is, I don't know. That's where my mind went.
Yeah, and I think the other part of fear that is interwoven is I'm struggling with finding it's sort of administrative fear. Like, it's just the way that medicine is administered. So many conversations. Well, I'll just say I've had a couple of conversations with folks, medical providers in particular, but this would extend over to behavioral health providers, especially directors as well. Just this sense of like, I've had them make this comment. I'm not trying to pump CFHA here, but they've said, I feel like I'm appreciated here, CFHA, more than I'm appreciated at my job. And there's something wrong about that. And I think part of that is that at the workplace, there is an element of fear there. It's not just like not being appreciated, but I think there's some fear related to, hey, are my RVUs going to be enough? Am I going to meet my goals from the quality department? Am I going to get dinged on this here? Am I going to be looked on negatively because I'm sick and have to stay home, and or my kids are sick and I'm not going to be seen as a team player? So I think there's these ways in which there's this fear of failing to meet all these standards and failing to meet sort of, standards, I guess, is the best way, or these expectations or these, strictures that we have in place in modern medicine. And it just like, I think that's a part of the unspoken morale drop that we have in healthcare. There's just so much burden on us that we just end up living very fearfully, I guess.
I think it's interesting the way that you languaged it a minute ago, Jen, of you feel like we haven't found a way to coexist along fear or to live alongside fear. And I think a lot of this ends up unspoken, even articulating, hey, there's fear running through this. Hey, there's, and you just cataloged, Neftali, a lot of different types of fear, a lot of different situations and scenarios we do have fear about. Some of it is about ourselves and our roles, and if we're doing enough or if we're doing the right things. Some of it is fear for our patients and what they're experiencing and what kind of outcomes they might have. Some of it is fear about how we're going to be perceived or the work that we're doing. And so there's so many different ways that it can come through. But I think if we don't name what's happening, if we don't name the existence of fear, the role that it's playing, there's a lot of danger that it's guiding us and steering our decisions without our conscious awareness. And so that's that piece that you said, Jennifer, like, what might it look like? And I think this is a question for a little bit later in the conversation, but what might it look like to acknowledge that it's there and figure out how to live alongside it, figure out what is an appropriate relationship to fear so that it's not driving us. And I see this, I think there are some clinical scenarios that do bring up more fear than others. And one often that I talk to my learners about is when we're treating pain or when we're treating, using, substances like narcotics, like opioids, to try to help patients with their chronic pain. And we have a gut reaction to that. We have some bias that maybe we're not naming in terms of what people need or don't need, or we're reacting towards what our patients. And I always caution our learners, especially, but I think this is true for everyone, no matter where you are in your career, to sort of take a step back and ask yourself, am I making this decision based on good evidence, or am I making this decision based on fear? Because we, hopefully we don't treat, cardiovascular disease out of fear, usually. Why would we treat pain or not treat pain because of our own fear? So I wonder, I see a lot of nodding from you. I'm curious, what are the things? Are there certain clinical scenarios? Are there certain, times when fear does seem to have a stronger role?
I guess I'd say I think fear comes up a lot from a medical provider standpoint when it's the out of the comfort zone, when it's the unknown. I think back to my clinical career of like not doing any type of formal substance use disorder treatment, and not for, I wasn't interested in it. I just wasn't exposed to it. So it was the unknown. It was like, oh, that's okay. That's a condition that we don't do here. Here's some phone numbers and some referral things that usually didn't go anywhere. So when our system got really involved in developing MOUD and collaborative care for co-occurring substance use OUD with mental health, it really was like talking to the providers on like, hey, do you want to get trained in buprenorphine? It was like fear of the unknown. Like, oh, well, doesn't that require extra training? And it did. At the time, you had to have the DEA X waiver and do 8 additional hours, 24 if you were a nurse practitioner. So by the system, it seemed scarier and more daunting. So it took a lot of not fear, bravery to step in and say, okay, I think I can learn that. And, that's a tough thing to be an adult learner and like admitting that you don't know something and that you need additional training. But so glad, so fortunate that we got support and training with that, because it's been a game changer in our community. Like just the mindset shift, like, we can look at opioid use disorder like a chronic condition and like, wow, that makes it seem less scary to me as a provider, right? Like, okay, I can do diabetes, I can do hypertension. So if we think of compliance and non-compliance and relapse with substance use disorders, that felt less scary. So you felt more empowered with further education. So just information, knowledge is power. And then community. So it was support, it was mentorship. Andy Saxon's my mentor. He's all the way out in Puget Sound. And I email him still years later with, what about this case? And this is a complex situation. But what made it less fearful is knowing you weren't alone. Just you've got somebody to call when you're in the deep end and things get scary. So yeah, I don't know. That's what came up for me.
Yeah, it's funny you say that, Jen, in those terms, right? Because you'd think like in sort of purely logical terms, if you split the head and the heart, well, yeah, so all you need is more education. And it's not just more education, you need to feel less alone, right? Because it's a
Correct.
fear-based
Yes.
response. And
Yep.
that's a perfect example of what the secret sauce of good team-based care is and what really good integrated care is. It's just
Yep.
helping people not feel alone as they
Yep.
face a problem and work together on it.
Yep.
So another tangible example of that, and I've experienced this across, I don't know how many, maybe probably over 100 providers that I've worked with in my career now, medical providers, is psychiatric prescribing, right? So when I first started, let's say at Access Community Health Centers, which is the FQHC in Madison, Wisconsin, many years ago now, that community had probably one of the most dysfunctional mental health you can't even call it a system, really no system. The community mental health center in the community, at some point during my tenure there, literally stopped taking Medicaid patients, which meant that we at the FQHC we started getting this backwash of mental health patients with severe and persistent mental illness, and they had literally nowhere to go. Nowhere for psych interventions or for psychotropic interventions. And yeah, that's a scary thing when you have someone coming in and they have bipolar or schizoaffective disorder, and that's out of your comfort zone. You feel like you're going to start practicing outside of your scope. You're alone in this, that kind of a thing. And, so my role became really just partnering with each provider and helping them feel more comfortable, more capable, giving them context as to what was going on with the patient, so that together we could make a good decision around whether we could take this care on or whether we were going to set a good boundary and say, no, this is outside of our scope. And most of the time we figured out ways to say yes together. And it became a thing where we were able to kind of grow competencies comfortably together. So simple things like, I started reminding providers. I said, you actually prescribe Depakote in other circumstances. right? When a patient has a seizure disorder, you prescribe this medication, you refill Depakote. So if we see a patient who's already on Depakote for bipolar disorder and they need a refill, we could do that. We could do that together, right? But it really is a lot more than just, if we could just hand out a PDF that says, hey, family medicine, you can do X, Y, or Z, that wouldn't be enough, because there's still that feeling of like concern. A, am I going to harm the patient? B, am I totally out of my scope? C, do I have the expertise to manage this, to handle this? Am I alone in this? Am I going to get in trouble? All those sorts of things start sort of interfering into really doing what's best for the patient. And as we like to say, practicing at the top of your license.
As you're like rattling off those questions that people are filtering through, I'm reminded that, fear, as with anxiety or as with mood changes or as with everything, is a problem when it's causing us impairment, because there's a certain degree of like healthy respect for the graph. We don't want to be glib. We don't want to be like, oh yeah, it's another safety plan, whatever. We don't want to come to the point where we are, just brazen, right? We need to have those questions. We need to be thinking about our scope, but we also need to differentiate when like, oh no, this is guiding me. This is ruling me and controlling my decisions. So what are some of the factors, whether, I mean, do we think it's more personal? Is it the system? Is it the larger healthcare system? Is it the specific organizations that are people working for? Like, what contributes to fear when you think about times when you've seen it the most?
I think it's a little different, like in each situation. So with suicide, for example, or suicidal ideation in a patient, which is another very common type situation, which we talked a little bit about at the end of last podcast. That one I think has a lot to do with our larger cultural messages, both culture at large and writ large, culture here in this country, in the world around suicide, and what we think about suicide, how taboo it is, really. And then also potentially the culture within the organization, whether there's, fear of like missing something, fear of not asking the right questions, fear of being looked down upon by your peers, honestly, for sort of not doing it right, whatever right is, right? So I think those larger cultural pieces definitely influence what is just good, sound clinical judgment and a recognition of the realities of suicidality, right? That we're never in control of patients' decision making and lives. Like there's no instance in which we are able to monitor someone other than if they're in an inpatient setting for 24/7 and ensure that they're going to not hurt themselves. Like that's just not what we're able to do. We're also not very good predictors of suicidality. So let's stop pretending about that. We have only certain things in our control. We can ask some good questions. We can provide therapeutic support, and we can have solid decision-making and evidence for situations where we feel like we need to have someone be in a safe place for a determined amount of time, right? And so when I try to coach people through those situations, I'm trying to move them off of that unhelpful fear and onto simply, what can you control? What are the things that you can do to be supportive and to anticipate the patient's needs as much as possible? And also just to try to turn this particular moment into a therapeutic intervention as much as absolutely possible. And then let go. Because whether you send them to the ED or you send them home, it kind of doesn't matter at that point, right? Like you have to let go either way, right? You can't hold on to the sense of responsibility around that or the sense of fear or shame that you feel about, how good or how poor a job you did at that. So I think in that situation, that's that set of variables. I think different fears in different circumstances, like, obviously it's a different level for those medical providers right now who are dealing with abortion litigation fear in different states, right? That's one where that's not just like all those dynamics we just talked about, but then it's like fear of like your livelihood and fear of like administration and legal, and then fear of that, those poor patients who are suffering with infections and other sorts of life-threatening issues that you're really concerned about. That's sort of a different category.
Yeah, it's topical for me with the suicide conversation. I just finished the Prosper training that CFHA heard about it through Kent Corso and Leslie Manson and took her class, and phenomenal, but just very different perspective on kind of unlearning what I'd always been taught, which was I think it's defensive charting, right? Well, just document that they didn't have an intent and plan. So then if something happens, we're not liable. Like I can't tell you how many times our teams have spoken like that. And the Prosper training was like, flip that totally upside down of like, helping people identify a suicidal mode and helping them develop their own resilience. I was just like blown away. Like it was so good and foreign to me that like I'm gonna have to retake the class in December when my colleague Kathy takes it, because it was so good that like I knew like I need to start doing this, but it's just so different than what I've always been trained that it's hard to flex that new muscle. But really great content with just acknowledging that we don't have control. We don't predict well at all who's gonna die by suicide, and that's a tough reality to live with, but we need to again coexist with that fear, right? That we can't control that. So yeah, very, very timely.
We should have Kent here. For those of you who don't know Kent Corso and Leslie Manson, they're longtime CFHA members, psychologists who, Kent in particular, has done a ton of training on suicidality all across the United States and Canada. I don't know if other countries as well, but we should have him on sometime.
That'd be great.
Because I think that's a perfect example of an area that fear really drives a lot of clinical decision making in those instances. I've seen so many residents, attendings, behavioral health professionals reacting in ways they would not otherwise react. This is very interesting. These are otherwise very calm, cool, collected individuals who face really difficult situations, both in the outpatient and inpatient settings. But once you start talking about suicide, it's like something flips and it feels somehow different.
Yeah. And I think
go ahead, Jen.
I was just gonna say, I think we, the primary care medical providers, we need more training on that. I mean, there's those statistics, right, that people usually reach out or see their PCP within a month before dying by suicide. Like, my goodness, we've got such a golden opportunity as an all integrated care to leverage that relationship. You know this person, they've seen you for a long time. Be present and really know how to make a impactful intervention if you get that opportunity to connect with someone before a tragic event like that. So go ahead, Grace.
I was just going to say it's a both and, right? Some of it is our own personal experience and personal traumas that we've had. Some of it is this larger system. But the thing that keeps running through my head as we're talking is the importance of doing our own work, the importance of differentiating between what is a healthy fear and respect and what is, back to what we said of like driving us and guiding our fears. But, I'm hearing as we're talking so many principles of acceptance and commitment, like accepting what we can't control and committing ourselves to the practices that are going to be in alignment with evidence-based practice and who we want to be as a physician. And then having emotional boundaries in terms of what we can let go of and recognizing that, okay, I do need to do some kind of self-differentiation work here and recognize that just because, I have had this experience or I haven't, or I'm afraid of this thing doesn't mean that it's true for everyone and doesn't mean, we may have different values around death and dying, for example, even if we're not talking about suicide and people making choices about treatment or testing, sometimes they can be fear driven. I think for us as clinicians, as we're trying to push our patients towards doing a treatment or having a test or, making a plan for whatever it is. I was having a conversation with one of our learners the other day who we were reflecting on some of our own like past history in our families and healthcare. And she said, now that I'm thinking about it, everyone in my family who has died at home. And that's been a big value. And it's been a really like lovely thing for our family and for as far as our togetherness. And then she didn't say this, and so I don't want to like assign this to her. But I think for some people who maybe have had that experience and that has been what they've held, they may be afraid of the idea of a patient dying in the hospital, or afraid of, you know, making a choice that's going to be out of alignment with what they think is best for their patients, when sometimes we need to differentiate that that's value based, or, okay, I had, this specific traumatic bad outcome for me as a provider, whether it was, a misdiagnosis of a cancer, or, whether it was a rare complication of some surgery or whatever. And so now every patient, I'm going to be on top of that. And I'm going to be driving that. And I'm going to be ordering things that maybe aren't appropriate because I'm so afraid that this is going to happen again. And I've seen that happen. And that's where we have to work through some of our trauma, our secondary traumatization, or the stress and compassion fatigue that we hold as providers too.
Yeah, absolutely. I think wow, it's probably, I don't believe in jinxing myself, but they say like, it's not a matter of if you get sued, it's when, and the stat, 1 in 3 physicians get sued in their lifetime, and it goes up to 1 in 2 after 55. So the longer you practice, the higher the chances. Knock wood, I've not been sued to date, but who knows what tomorrow will hold. But I think holding space for people who have had that experience, because it's easier for me to sit here and say like, oh, well, don't chart defensively. Had I been the one that had been through a terrible outcome that was heartbreaking, and then, sued on top of it after feeling like you did your best and it broke your heart too that you had a bad outcome and lost someone, my goodness, I'm sure sing a different tune of empathy of like, hey, it is traumatic that in the workplace, in the field, you're doing your best and you still have this traumatic thing happen that is out of your control. I guess just wanting to hold space for those people too, that lived reality is extremely common, and you feel for them because, I think we're all kind of doing the best we can, right?
Yeah, and that's so important. I'm so glad you said that, Jen, because I don't want anyone to hear us saying like, don't be afraid, stop being afraid. Because if that is something that is part of your experience as in healthcare, or that's part of your experience as a clinician, that is a heavy thing to carry. And I have so much compassion and so much empathy for that. And it is a hard thing to work through. Back to what we were talking about earlier, whether it's more of a just temperament, personality trait, or whether it's a specific traumatic experience that you have had, or, an acknowledgement of the systems that we're working in, and the failures of some of those systems, and the way that systems have, sometimes intentionally pitted patients and providers and systems against each other. I just have so much compassion for the presence of that fear. And what you said earlier, Jen, that you're not alone. Walking through a dark place is a little bit lighter, a little bit less scary when we know that we're not in it by ourselves. That's so important.
Here's a good resilience skill that just, as you guys were talking, it dawned on me like how I cope with these things and how I've seen healthcare providers cope with these things more effectively. And what cued me was when you're talking, Jen, about defensive charting. And I was like, well, I don't think I chart defensively, but I chart wisely. So I know that the legal audience is one of my audiences when I'm charting. And so if they need me to put, patient denied suicidal intent, has, no means, whatever, right? I'll do that. But what I have learned to do is to separate out sort of the dysfunction and or traumatization of the system from my participation in it. And so that, and I think there's a healthiness, there's a resilience that comes when you learn how to be in a space without being managed or sort of controlled by the space. And since so many healthcare spaces, unfortunately, have a fair amount of dysfunction in them, what healthy, resilient people learn to do is to essentially compartmentalize and say, okay, these are activities, behaviors, things that I do to sort of abide in this space, right? So defensive charting would be one of those sorts of things, right? But then to your point, Grace, there's this strong center of values and role and a strong center of who I am as a healthcare provider and as a teammate that really guides how I operate and feel and think about myself. And if I operate more in that space as opposed to the other space, then I feel like I'm functional in that space. So that's sort of a way to live. And we do that all the time in behavioral health circles because we are constantly helping patients live in dysfunctional spaces. It could be a dysfunctional family, it could be a dysfunctional work environment, a dysfunctional relationship. We're constantly helping people kind of be adaptive because we know we can't change those spaces directly, or maybe the patient has no access to change that space directly. I'm thinking of many of my kids that I work with, right, who are in spaces and they got the parents they got, and I've got to help them do their absolute best with the parents they got, right? Sort of that same sort of dynamic. I don't know if that makes sense to you guys, but like that's what dawned on me is like that's part of the skill of working in healthcare today.
I was just cheering. I was just going to say yes, 10% or whatever, 10 out of 10. Agree.
Yeah. Do we have any thoughts to share with someone who maybe is seeing this in themselves and feeling this in themselves in terms of fear and trying to, we've had little nuggets along the way, but any words for someone who maybe is experiencing this as a really significant part of their practice right now?
I think some themes, Grace, you're better at this than I do in terms of how you summarize these things and bring them all together. But I think it strikes me that not allowing yourself to be alone in the experience is a huge piece of it. So when I talk about that resilience that I just talked about, I did not develop that myself. That's something that I think I developed in community. So the teammates that I had and talking things out. We've talked about naming the fears. Like that's, if you just say it out loud, just say out loud what it is that's going on. That's almost 90% of what's going to get you to a better place, more grounded place, a place where you can productively engage the fear with your values and with those parts of you that are the strong parts of you.
Yeah, I think we need to do some externalizing and thinking about, what is our relationship to fear itself? And it lies to us, right? It tells us that we're the only one feeling this way. It tells us that if we name this, other people are going to think that we're weak or are going to belittle us or that I think sometimes we're afraid that we're right, when if we're afraid that we're not doing a good enough job or that we are failing our patients or that everything is going to turn out bad or we're a fraud, we're afraid of that being confirmed that we're right. But having that community and being able to voice even a little bit of that and to hear from someone else, oh my gosh, me too. Or, to hear that reassurance, it takes bravery. And I tell my kids all the time that you don't have to not be scared to be brave. That is not, those things are not, exclusive. Being brave doesn't mean that you don't feel afraid, but it means that you feel your fear and then you choose the thing that is the right thing to do, or you choose the thing that's going to be connective and take you into relationship and not be alone with that. And so that would be a piece, I think, to have that first little step of voicing a little bit of it. And if we can say, hold on, fear's telling me this, I need to check in with someone, that can go a long way. And then, getting treatment. We're so bad at that in ourselves in terms of recognizing also, I've been on my soapbox a lot about dysregulation and what that does to us, and fear is very dysregulating. And if we can center ourselves and calm ourselves and even focus on some of our physiological re-regulation, then we can start to think through maybe what's real or what's not real, or how we can find that connection with someone else.
Yeah, and Jen, like you just took that Prosper training recently, correct? So how did that,
Yeah. Yeah.
what did that do for you fear wise, right? Like, did that, I mean, I'm not trying to make you, you
Yeah.
don't say,
No, no,
oh,
no.
it's transformative, but I'm just saying, like, how did that,
Yeah.
curious what that felt like from a medical provider standpoint, like the good
Yes.
training that
Yeah.
usually behavioral health folks are taking, right? How does
Yeah.
that feel?
It just feels like another skill in the toolkit and a deeper understanding of what we can do as providers. Like, I think medically you feel like it's you make a diagnosis, you give a pill, you whatever, chart defensively, and then go on to your next patient. It's like there's more to it than that. And I don't know, Prosper just kind of helped me realize that with some additional training support and community, like, hey, you can practice in a way and have deeper, more meaningful conversations with people that aren't going to necessarily put you behind and make you spend an hour with one person and ding your RVUs. But if you get some skills on reframing instead of just the defensive, oh no, do this form so that if it's a suicide outcome that we're not held liable. It's just a different mindset of like skill building and supporting patients instead of just freaking out and charting in a way that you hope doesn't get you in trouble down the road. Does that make sense?
Yeah.
It was good. It was really good.
Yeah.
Yeah, so sometimes it's education, sometimes it's connecting, filling those gaps, finding that connection. And then I think there's a piece of like reminding us of the bigger world that we live in. It can be fear also, and anxiety, really limits our perspective. And if you're not watching, I have my hand way up in front of my face because it's like the only thing that we can see. And so whatever it is that connects you back with meaning in and out of medicine, right? Spend some time outside in nature and remember the world that's bigger than us and contextualize the work that we're doing as a part of us, but not all of us. And finding beauty, finding connection, finding meaning, I think is also helpful for anchoring when it feels like we're starting to get lost in a sea of anxiety and fear.
Yeah, or one of the other things I often work with patients on is just making friends with your fear.
Mhm.
Just realizing it's just a reaction, it's just a sensation you're experiencing. So let's figure out what it's trying to tell us.
Yeah, it's
And
information, but it's
yeah,
not fact.
that's right. Yeah,
Mhm.
yeah. And I think from a medical standpoint, I think the complexity comes from the fact that I think there's this expectation that you're somehow a little bit more than human and not supposed to feel fear, right? You're supposed to know everything. You're supposed to have it all together. You're supposed to be able to figure everything out. And although it's not explicitly stated in any medical curriculum that I know of, you're not supposed to feel afraid. And that's pretty silly if you just say it out loud. That's just pretty silly. And it also tells us a little bit about how we are potentially or have traditionally trained medical providers, especially. I would say this is somewhat true of behavioral health as well. Instead of thinking of of people in context, shout out to Bridget here, you know, we we've trained individuals, right? Sort of bounded individuals who are supposed to have everything together. And to me, it's just a very different thing when I think of we're not really training individuals, we're training teammates. We're training future teammates. And in that context, these teammates should have the not just internal capacity, but also the external context of team to help them face fear productively, to face it not alone, but to understand that fear is a normal response that you need to respond to. There needs to be something that you do with that, and you don't have to deal with that on your own. So I would say that's one of the things I would tell anybody listening out there is like, do not isolate. Do not think of yourself as going through whatever clinical scenario by yourself, even if you're not a learner, right? If you're not a resident, doesn't mean anything. One of the things I love about family medicine residency is Grace, this, and you've got your table where you've got your precepting folks and everything, and attendings will come in who've been there worked for 10, 15 years, and they'll come and ask the preceptor, hey, what would you do in this kind of scenario? How do you deal with this situation? Hey, I'm a little unsure here. And it's easier to do that for a medical issue, right? Maybe some sort of skin condition you haven't seen in 20 years or whatever. but there's no more shame. There shouldn't be any more shame attached to other types of situations that are just about emotional complexity with your patients, psychiatric complexity, substance abuse, or any other sort of competency area where you just feel like you might be out of scope. It's just, that's okay to ask for help. And that should be part of your identity, that you're a person who asks your team for help.
Yeah, I love that. Well, this has been such a good conversation, and I think comforting for me, and I hope to our listeners too, that the reassurance, it's been some time since we ended with the closing meditation, and I don't know that I can totally do Deepu's justice, but I was
You
reminded
got it,
by,
great.
okay,
You
well, I'll
got
do
it.
my best.
Just deepen your voice a little bit.
I'm not even going to attempt that. I was reminded by this poem that is attributed to Rumi called Keep Walking.
Mm.
Keep walking, though there's no place to get to. Don't try to see through the distances. That's not for human beings. Move within, but don't move the way fear makes you move. Today, like every other day, we wake up empty and frightened. Don't open the door to the study and begin reading. Take down a musical instrument. Let the beauty we love be what we do. There are hundreds of ways to kneel and kiss the ground. Thank you, Naftali and Jen, for being here with me today. Thank you to our listeners, and we'll talk to you again soon.